A very good evening to one and all, respected chair and panelists. And at the outset, I'd like to thank the organizers and for giving me this opportunity, which is incredible and interesting at the same time, because I'm a black sheep among this elite crowd. I'm an endocrinologist. But the topic assigned to me today is drugs for weight loss, and I shall be talking about our bit of experience with oral semaglutide. So when we talk about weight loss, much has been said and done, but we should know how much is much. So regarding weight loss, in fact, this is one of the reasons why a criteria to define a drug as a weight loss reducing agent starts with the 5% benchmark. The benchmark is set there because the benefits, as you can appreciate, they actually start from weight loss of around 5%. So be it with type 2 diabetes prevention, but for type 2 diabetes remission, of course, you need a higher weight loss. And for the interest of this audience, for NAFLD or MASLD, the benefits start as early as 5%, but for more advanced stages like fibrosis, you need a higher weight loss. So obesity is a challenge. And why is it a challenge? We have several options. We have diet, we have lifestyle, we have exercise, we have a plethora of drugs, many more in the pipeline. We have bariatric or metabolic surgery. But the fact that there are so many options itself says that we have not been able to address the problem essentially well. And one of the major reasons here is because obesity is rarely or more often than not recognized as a chronic and relapsing condition. In fact, there's a new terminology for the condition which many of you may be aware of. It is ABCD or adiposity-based chronic disease, which is a term which should be reiterated to the physicians and the patients alike. Despite all that is said and done about diet and lifestyle, overall, if you look at the figures, less than 1/3 of the patients actually achieve significant weight loss. And nearly half of these patients only are able to sustain their weight loss. Because what happens when a person loses weight? There are multiple neurohormonal mechanisms that take place, starting from reduction in the leptin, increase in the ghrelin, increase in your appetite. And once you lose body weight, there was a prior discussion also, you definitely lose lean mass. And once you lose lean mass, your BMR reduces. So there is a tendency of the body for the homeostatic mechanism. So in all these, in this entire hierarchy of obesity management, what is the place and role of anti-obesity drugs? So if I can draw your attention to this small graph here, so low-calorie diet with any form of exercise in this meta-analysis, it showed that the effect size is only modest. But on the other hand, if you look at the graph on the right, so the anti-obesity drugs compared with all the diet and lifestyle measures. So there are 2 take-home points here. One is that with overall all the anti-obesity measures or medications combined, the weight loss was significantly higher. But very importantly, it lasted for a significant duration, which is very important when we are managing a chronic disease. Now, one might argue about the dramatic response that is seen with bariatric surgery, but one should also remember that around 60 to 80%, they regain their weight up to various extent. And even here, the anti-obesity medications play an important role, as shown in this figure. So we know the real importance of anti-obesity medications, but if you look at the other perspective, as the patient is walking into the clinic, if he or she is given a choice as to what he or she should choose. So this simple study, it actually showed that patients really opt for only lifestyle management and in the majority of the cases, and the medication is resorted to in less than 1/4 of the patients. So one of the important reasons for this can be this quest for the ideal anti-obesity drug, which has been arduous. It has been there for nearly 8 decades now, and it is ongoing. And the other thing to note is that the journey has also been dubious, because we see that the grays outnumber the reds. So grays are all the drugs that have been withdrawn. More recently, the lorcaserin, due to increase in incidence of certain cancers. So this is the list. Now the list becomes much smaller because this is the currently approved, FDA-approved pharmacotherapeutic agents that are available. So we have orlistat. We have phentermine alone, but that is again approved for a short duration. Phentermine, topiramate, naltrexone, bupropion, liraglutide, and semaglutide subcutaneous. So just a moment to just recollect the biology of the obesity. That is the arcuate nucleus in the hypothalamus, as you can see here. That is actually the seat of regulation of body weight. So you have one group of neurons which are the orexigenic, that is the AGRP and neuropeptide Y, and the other group of neurons, that is the POMC cart, which are anorexigenic. So you need to have a drug which sort of stimulates this POMC cart, And there we have 3 green signals there. So one is the GLP-1 agonist, one is the lorcaserin, but again that is out of the picture after it has been banned, and then is the naltrexone. So this elegant network meta-analysis published just a few years back, it is comparing all the drugs. And as you can see, because it is in 2016, lorcaserin is still there. So just leaving aside that drug, if you look at the overall efficacy, the number 1 and number 2 drugs would be the phentermine topiramate and the liraglutide. But also at the same time, I must draw your attention to the adverse effects. It is also probably one of the highest with these 2 drugs as well as with naltrexone. So overall, if we rank these drugs, so it is phentermine, topiramate and liraglutide, which are in fact the front runners. So this is just to show the weight loss efficacy of the drugs, which we've already discussed. But also on the other hand, at the right side, we need to assess the dropout rates, because as you and I will agree, it's a chronic condition and we need a long-term adherence to these drugs. So all the drugs have very high dropout rates, but we can appreciate that liraglutide there is the lowest among the list. So less than 1/4 actually drop out due to adverse events. So now the picture has changed, and these are certain new kids on the block. So semaglutide and tirzepatide. Tirzepatide we know is not available with us. Semaglutide we only have the oral form. So as you can see across the spectrum, the orange bars actually represent the percentage of weight loss with as compared to a placebo, not an active comparator here. But the weight loss magnitude is significantly higher with Sema as compared to the other drugs. Now here these 2 stars are just to reiterate the fact that all said and done, we should do what we have with us. I mean, we can use what we have with us. So tomorrow if a patient comes to your clinic with this problem, you should know that the only 2 efficacious options which are available are Lira and Sema. Now, one of the important goals in weight management is a negative energy balance. There are multiple ways to do it, but targeting appetite is one of the key regulators, because we know that that is one of the major factors which causes the patient to regain weight after he or she has lost it. And in this aspect, I would just briefly like to highlight the central role of the GLP-1 agonist, which we briefly discussed. But this picture also shows the functional MRI studies done to show various aspects of the brain, starting from the hypothalamus, the various areas of the cortex, visual, orbitofrontal and parietal. They sort of light up in response to calorigenic foods. So what is the role of GLP-1 agonists here? So this study with the liraglutide, it showed that there's a significant reduction of this visual response to calorigenic foods, and that is something which makes these drugs really efficacious. So moving on to GLP-1 analogs, the pleiotropic agents, they are the backbone of current anti-obesity therapy. So just about the long-acting agents, so we have Lira, Sema, we have exenatide, LAR, we have Dula, but the weight loss efficacy is at modest at best. And the physiology to pharmacology of the GLP-1 agonists. So we have native GLP-1, which is abundant, released from the L cells of the intestine. But what is the problem with it is it's very short half-life. So there are modifications to this. So you have Lira and Sema, which have very high homology to the native GLP-1, but they have albumin binding, which makes them long-lasting. So this is the list of all the GLP-1 agonists that are available with us, all approved for diabetes, but only 2 approved for obesity. And with semaglutide, just briefly, we know that it's the world's first oral peptide, and this utilizes the phenomenon of SNAC, that is sodium aminocaprylate, which sort of creates it, improves, or it makes the peripheral acidic pH in the stomach around the capsule less acidic, so that the drug is not metabolized, and then it is also a permeability enhancer. And that is how we have circumvented the issue of compliance. Now, we know that the entire picture is now boiled down to Lira and Sema. So is there a head-to-head comparison between both? There is. So interestingly, for A1C reduction, both the drugs, actually oral Sema was non-inferior, as you can appreciate in this trial, in the estimated treated difference reaching only up to less than 1.2%. But if you look for weight reduction, there is a clear superiority margin of oral semaglutide, and that sort of stamps oral semaglutide as the drug of choice. So after we have talked about compliance, there is always the issue of cost, especially in our settings. But in this very simple study, so data was drawn from the scale and step 1. So just to put in a nutshell, the weight loss was nearly double with Sema. And at the same time, when they analyzed the cost for 1% reduction of body weight, that was half for Sema. So the benefits are sort of quadrupled. There was also another concern because the plethora of evidence is available with subcutaneous formulation. So is there any issue with the oral formulation? Well, the good news is that it is not so. The efficacy of A1C and weight reduction is comparable for both. So briefly, I'll be talking about oral semaglutide, our experience, and I thank my senior co-authors for this opportunity. So GLP-1 receptor agonists in NAFLD and MASLD, multiple cardiometabolic benefits. They are potent weight loss reducing agents. And of both of them, SEMA is more potent as we have seen. There's an oral once daily preparation, so there's more compliance, convenience, probably more cost effective as we've seen again. And the more important thing as you and I sit here is that it is available with us. So we performed the study. It was a prospective pilot study, 52 weeks duration, open label, interventional study. Obese patients with type 2 diabetes and NAFLD as defined by the INASL guidelines. They were enrolled and this was the exclusion criteria. We used only VCTE to diagnose and stage the steatosis and fibrosis, both at diagnosis and during follow-up. And DEXA was used for body composition. So very quickly, these are the baseline results and all patients had steatosis, 95% had severe steatosis and nearly 70% had clinically relevant fibrosis to begin with. So because the topic today is discussion about body weight, so the body weight and BMI both showed a very steady and a very gradual and sustained decline till the end of follow-up. And then we performed the analysis whether there was a gender-specific difference. It was not so. But what we found that those who lost significant amount of weight, they were relatively younger, almost by a decade. Now, of course, we have to see the proportion of patients who had significant weight loss. So that number was nearly 2/3 at 26 weeks and nearly 50% at the end of 52 weeks of follow-up. But of course, it's an ongoing study and more data is still to come in. Now, as we know the limitations of body weight, so we did the body composition with DEXA. So very interestingly, this graph actually showed that there was a significant reduction in body fat percentage, both at 26 and 52 weeks. But there was no change in any of the other adipose or lean indices. So this is one very important take-home point, that if you're reducing significant amount of body weight and body fat without any significant change in your lean mass, that is something which can be a really big plus point. This is just to highlight one of our patients, a 52-year-old female. This is how she came. Her BMI there was 45. How she is above the line, above the percentile line, and at 52 weeks follow-up with oral SEMA, how she is reduced, and the body fat percentage, is reduced to 45%. So again, as expected, there was improvement in the glycemic profile, and in the lipid profile, we also did find a significant improvement in the HDL. So this was actually the primary outcome. So we had a reduction in the mean CAP which was non-significant, but also we found a mean LSM reduction. Admittedly, it's using only a VCTE, non-invasive study, but nevertheless, there was a mean LSM reduction at 26 and 52 weeks. So adverse effects, almost universally, patients had loss of appetite, nausea, vomiting, as expected in 2/3 of the patients, but very important to know that it was transient. And it was self-limiting. No patient was hospitalized for the same. There was no case of clinical pancreatitis, despite a very mild, non-significant elevation in pancreatic enzymes. So from an endocrinologist's perspective, these are the practice points which I could gather from our evidence and from the evidence available. So pharmacotherapy for obesity, as you will agree with me, is an exciting and expanding arena. Currently, incretins form the backbone of the pipeline. Oral SEMA is an efficacious option for obesity management. It causes substantial weight loss. It has beneficial effects on multiple cardiometabolic parameters. So we have seen the effects on glycemic control, improvement in HDL, hepatic steatosis, and fibrosis. The adverse drug effects are extremely common, but they are extremely tolerable at the same time. So drug discontinuation in our setup is more likely to be due to cost than due to the ADR. And liraglutide at higher doses is also an efficacious option. So again, I'd like to acknowledge Professor Badada and Duseja for this opportunity and my team members, and I'd like to thank the organizers and the audience for giving me the time. Thank you.